USMLE style question on leukocyte adhesion deficiency, LAD. Question: a 2-week-old male newborn is evaluated for a persistent umbilical cord stump that has not fallen off. He was born at term via an uncomplicated vaginal delivery. His parents report that his umbilical stump appears swollen and mildly erythematous, but without pus formation. He also had recurrent bacterial skin infections that were non-purulent. Laboratory findings: leukocyte count 45,000 mm high, neutrophil count elevated, flow cytometry absent CD18 expression on leukocytes. Which of the following is the most likely cause of this patient's condition? A. Defective lysosomal trafficking regulator protein, LEST. B. Defective CD18 integrin expression on phagocytes. C. Impaired respiratory burst due to defective NADPH oxidase. D. Defective microtubule function affecting neutrophil chemotaxis. E. Failure of third and fourth pharyngeal pouch development. Answer: B. Defective CD18 integrin expression on phagocytes. Explanation: this patient presents with leukocyte adhesion deficiency, LAD type 1, an autosomal recessive disorder caused by a mutation in the CD18 gene, which encodes the beta-2 integrin subunit. CD18 is crucial for leukocyte adhesion and migration. Without functional CD18, neutrophils cannot adhere to the endothelium and fail to migrate to sites of infection, leading to classic USMLE clues: 1. Delayed umbilical cord separation, 21 days. 2. Recurrent bacterial infections, skin mucosal. 3. Lack of pus formation, neutrophils can't migrate. 4. Marked leukocytosis, high WBC count, neutrophils trapped in circulation. Key features of LAD type 1, findings in LAD type 1, genetic cause, CD18 mutation, no B2 integrin, leukocyte function, neutrophils can't adhere and migrate, classic sign, delayed umbilical cord separation, 21 days, infections, recurrent bacterial infections, SP skin and mucosa. Pus formation, absent or minimal, neutrophils can't migrate, leukocytosis, 20,000 WBCs cytometry, absent CD18 expression, flow cytometry for CD18, treatment, bone marrow transplant curative, prophylactic antibiotics. Why not the other options? A. Defective lysosomal trafficking regulator protein, describes Chidiac-Higashi syndrome, CHS, which presents with giant granules in neutrophils, oculocutaneous albinism, and neurological defects. This patient has none of these features. C. Impaired respiratory burst due to defective NADPH oxidase, describes chronic granulomatous disease, CGD, which causes catalase-positive bacterial and fungal infections, e.g. S. aureus aspergillus. Patients have normal pus formation and normal umbilical cord separation, unlike LAD. D. Defective microtubule function affecting neutrophil chemotaxis, describes Chidiac-Higashi syndrome, CHS, which presents with recurrent pyogenic infections, albinism, and giant lysosomal granules. LAD lacks these findings. E. Failure of third and fourth pharyngeal pouch development, describes DeGeorge syndrome, which leads to thymic aplasia, T-cell deficiency, hypocalcemia, and congenital heart defects. LA presents with neutrophil dysfunction, not T-cell deficiency. Key takeaways for USMLE: LAD type 1 equals CD18 mutation, defective leukocyte adhesion. Triad: delayed umbilical cord separation plus recurrent infections, no pus formation. High neutrophils in blood but absent at infection site. Diagnosis: flow cytometry, absent CD18 expression. Treatment: bone marrow transplant, curative. Would you like a question on chronic granulomatous disease?